Hello, good afternoon from sunny Queensland. My name is Lieutenant Nick Hill, and this is ECGs, the absence of the normal. That's pretty self-explanatory because what we're going to do today is the baseline of what normal ECGs look like. So, moving on. So after this, you should be able to perform an ECG correctly, describe what an ECG is, understand the main features of an ECG, identify basic normal ECG features, and then distinguish between ECG arrhythmia and artifact or noise, if you want to use that term. So, electrode placement in a 12-lead ECG. Before we crack into this, let's talk about some basics. ECGs can be a 3-lead, which is common in anesthetics, a 4-lead, which is common in paramedicine, sometimes in emergency medicine, and then 5 leads are very, very common in emergency departments. Some emergency departments, depending on their level of patient care, will want a continuous 12-lead ECG in situ, and that patient, generally speaking, is a cardiology, heart failure patient, etc., that needs ongoing telemetry for admission or transfer to a cardiology centre. So therefore, V1 to 6, as you can see in the green circle, correspond to different angles of approach and vision for basically what leads represent what. And we'll talk about that in a couple of slides' time. If we move on, some manufacturers have colorized systems and some differ. There are some ways to remember this. There's smoke over water, so gray and black, for example, and blue. But then there are other manufacturers that make certain colors with red, yellow, green, and black. Now, for limb electrodes, a good way to remember this, if you have these colorized systems on, say, a Zoll, a Draeger, and I think some of the General Electric monitors, is right arm red, left arm yellow, left leg green, right leg black. And a good mnemonic to remind yourself of that and reinforce your learning is ride your green bike. Now, if your colors are different, totally disregard what I said. But one thing to take away from this is that normally manufacturers create the right leg as the dummy electrode or neutral electrode for ECG monitoring. So it's a good or useful thing to remember that your bottom right or your right leg is a neutral electrode. So, some basics. Before we get into the V's and where they go, one thing I like to remind a lot of students and new graduate nurses who work in emergency departments in particular is in the rush of getting an ECG for an acute chest pain, don't forget to charge and plug in the device before you do the ECG. That is relative for our paramedics in the back of the bus. Before you start your shift, plug in your monitor. Make sure it's fully charged before you get on the road. Make sure at shift changeover that all the electrodes are there on the equipment ready to go. Because when you have that acute MI, myocardial infarction or chest pain patient, it's very, very challenging to find the equipment when you've got that high cortisol level, the stress is running through you, the adrenaline's jittering your hands, getting excited, and you forget where electrodes are, or the ECG machine then dumps its charge and then you're stuffed and you have to plug it back in or delay care because of that. So, top of the list, check your equipment, make sure you've got enough kit to go with it, plug your machines in at the start of your shift, plug them in when you first see your patient so they don't die on you. Cool, enough of that. Moving on, electrode placement. For chest electrodes, V1 is on the 4th intercostal space and it's on the right sternal side. So the patient's right. On the image in front of you, you can see it's the left side of the sternum there, and it's on the 4th intercostal space. There is some odd teachings sometimes that draw them up to the first intercostal space or even the second. In actual fact, it's meant to be the 4th intercostal space, okay? So it shouldn't be high and tight and right up on their manubrium or the top of their sternum. No, it should be a bit further down. So a good way to find the 4th intercostal space is to palpate the manubriosternal angle, or the angle of Louis, which is right at the top of your sternum, right where your neck basically meets your sternum. Come down and directly adjacent to the second rib with a second intercostal space, and then go down again, palpate inferiorly, and then find the third and fourth intercostal space. And obviously V1, V2 are left and right, or right and left, depending on how your anatomy is of that sternum. V4 is placed over the apex of the heart, and then we go V3. So my teaching for my dudes is normally go V4 and then come back to V3, because V3 is a halfway between V2 and V4. So it sounds a little bit arse about face, but in actual fact, it's quite useful to go to your V2, go V4, and then come back to V3 to find that halfway between the two of them, not only laterally, but also your up and downs. Cool? So V5 then goes to the same level as V4, but it's on the anterior axillary line. Now, for most Defence Force medics who can decompress a chest, they normally do this well before they do their ECG lessons. So therefore, they have good understanding of where the anterior axillary line is. Okay, so you can see it on the diagram in front of you. But then on the V6, it's coming around at the same level as V4 and 5, but it's on the mid-axillary line, okay? And so we can see that halo as the lines drag down to the bottom there, and it then moves around in basically a circle, encircling the heart. So V1, 2, go V4, then put on V3, then go 5 and 6. And then you're basically working your way around to the axilla. Cool? Okay, leads. Now, how are 12 leads on the ECG? Where are they and what are they doing? So lead 1. Lead 1 works from your right to your left, and it's a polarization system, okay? So it's going from a negative polarization to a positive polarization, and it's moving across the shoulder, quite literally. And so it's formed using the right arm going across the left, as I've just said, and it's positive, okay? So it's in a positive electrode. That's a good way of understanding basically your polarization and the conductivity, the electrical conductivity of the heart. Cool. When we then look at positive and negative polarization, as I just explained with, say, lead 1 on an ECG, then understand what, in a clock ray method, placing a clock directly over the top of the anterior anatomy of the heart, we can then see how it's laid out. Really straightforward, very simple diagram here, which understands your positive polarization and your negative polarization. And for me as a new graduate nurse, no one really gave me formal education on this, and so it took me some time for some of my mentors to later teach me, some of my better mentors to later teach me about this clock ray method and what it represents on an ECG. And so we can obviously see on this chart, and I don't know if I need to explain too much depth about this, but basically the negative polarization being the top portion or top half, and then the positive polarization being the bottom. And then we can see the relative parts of a 12 lead ECG and what they represent. Cool, so we can see lead 2 and 3, AVF down the bottom there. Off to the right in the 3 o'clock position, AVL and the first lead. AVR, top left. Cool. And so those are our negatively polarized leads. Lovely. So when we move, so limb leads and what they tell you. So they look at the coronal plane of the heart. AVL 1 and 2 are lateral coronal planes. 2, 3 and AVF are inferior. AVR is the right-hand side of the heart. Cool. So what is the takeaway from this? Well, if you're going to put monitoring on someone, the limb leads are what matter to start. They are the placement, generally speaking. It's okay to put them on the deltoid or the head of humerus for the left and right arm. For your leg leads, it's okay to put them on pretty much the angle descending on the abdomen and right on the edge there. They don't have to be out on the hands or the feet. I will probably get some cranky nurse educated from cardiology telling me that's inappropriate or not correct. However, that is satisfactory. A troubleshooting thing you can do with the most basic level of ECG rhythms is that at least 3 leads will get you a rhythm. So some monitors such as the Draeger and the Zoll with 3 limb leads will give you a rhythm. So that's left arm, left leg. And then obviously you need to apply the dummy lead down on the right leg. And that will give you a basic rhythm. It will not give you a 12 or a 5 obviously because that's only 4 leads. Yay maths. But the basics of this is that if you don't get a rhythm strip up on your screen and you've applied all your electrodes, then troubleshoot the limb leads first, then go through your V leads, V1, 2, 3, 4, 5, 6. Cool. And that's basically around, hey, why am I not getting a rhythm when I've just put the electrodes up? And that's checking your limb leads, okay? So just troubleshoot. So we have in front of us a normal sinus rhythm. This is a nice easygoing rate. The R interval, and we'll talk about this later on, is normal. So there is a P wave. This patient is stable. If we look at the ECG, we know that lead 1 represents the lateral view of the heart. AVL represents the lateral view of the heart. 2, 3, and AVF represent the inferior view of the heart. AVR looks at the right side. Okay, so the basics of it is that the limb leads will give you lateral, inferior, and right sides, okay? And that goes back to the slide that I talked about at the start and the coronal views that you're looking at. Because the V leads, then what we're about to segue into, we'll start looking at anterior portions, anterior septal, lateral, and ventricle views of the heart. And this will make a bit more sense in about 2 slides' time. So leads and what they can tell you. Each lead can be thought as looking at an area of myocardium. And so chest leads or V leads look through on a transverse plane. So we talked about the coronal view with limb leads. With V leads, they work like a disc or a plate going through the heart. So V1 and 2 look at the anterior of the heart and the right ventricle. V3 and 4 are the anterior and septal views. And so the septum, or the septal view, is that meaty part in the middle of the heart that divides our lefts and rights. And then V6, V5 are looking at a lateral and left ventricle view. And I think this next image is a real aha moment for me, especially as a new graduate, to help break that down. We can see our anterior going through posterior, and this is a normal 12-lead ECG. So this is not a posterior 12-lead ECG, this, or a 15-lead, some people call it. This is a anterior 12-lead, as per the anatomy that I talked about several slides ago. And so this is working on a horizontal plane. You can see the orientation in relation to the body there. And you can see what the normal sinus rhythm looks like with that horizontal plane dividing the heart and bringing a representation of that rhythm. So this slide breaks down our V leads. So V1, as I talked about before, and feel free to pause and go back, is the anterior and right ventricle. V2, anterior and right ventricle. V3, anterior septal. V4, anterior septal. V5, lateral. V6, lateral. And so V5 and 6, let's not forget, is the left lateral view, whereas V1 looks at it from a anterior and right ventricle view of the patient. So V1, V2. So it's an important part to remember. So electrode placement in a 12-lead ECG. The basics are what matter, and this is comes down to the core of what this is about in this presentation, in that the left limb lead, for example, goes to the patient's left, not how you orientate to the patient, because that then inverts it, which then can cause things like T-wave inversion, which is a sign of old ischemia, for example. So placement of limb leads is really, really, really important, as is the correct placement of V1 through to 6 and where they are on the anatomical structure of the patient. And one thing that happens quite a lot is that we put limb leads on, say, big-breasted men or women. We misplace them and we start drooping further and further down, which then moves anatomy, then moves what the ECG rhythm looks like, and then we get a misrepresented image of what the rhythm looks like. We get low voltage, for example, and then low voltage ECGs don't represent exactly what's happening. So for that, find the anatomical structure and don't let the breast tissue of either a large breasted man or woman dictate where you place your electrodes. So elements of the trace and elements of your rhythm. These are all really important, all these intervals. And breaking them down per presentation or physiology or age and stage is a big thing to unpack. But basically the thing to take away from this, and feel free to pause the video, is understanding what segment represents what part of the heart's electricity and conductivity. And the next slide will break that down. And again, for me as a new graduate, this is a real aha moment in seeing what they basically mean. So let's look at how the conduction system relates to what we record on an ECG, what comes out on the piece of paper or on the screen. A P wave, this is the sequential activation or depolarization of the right and left atria. The QRS complex is the right and left ventricular depolarization, and normally the ventricles are activated simultaneously, okay? The ST to T wave is ventricular repolarization. The U wave is not that clear about its origins and why it exists, but probably represents an after depolarization in the ventricles and sometimes is present in hypokalemia. And that's quite common. PR intervals, time interval from the onset of atrial depolarization, which is the P wave, to the onset of ventricular depolarization, or the QRS complex. The QRS duration, or the duration of ventricular muscle depolarization, is one of our most important parts of an ECG, and that comes down to a few physiological presentations, but also some interactions with drugs, and can sometimes be an important part of overdoses, etc. The RR interval is the duration of ventricular cardiac cycle, or an indicator of the ventricular rate, and the PP interval is the duration of atrial cycle. And those two last ones in particular are really important to be able to get a good understanding of what is normal for our patient and if it's regular or not. And we'll talk about that in a second, about the exacts of what that looks like and how we do that. So, interpreting the ECG. Now let's just take a pause point here and talk about some logistics and basic administration stuff. Talking to your patient about why you're doing an ECG and why you put sticky dots on them and why you're printing it out, either pre-hospitally, in a hospital, as an outpatient service, whatever, is really important. And most patients that are cardiology or known comorbidity patients who get an ECG will know what's up and why they're getting it. But that patient who is acutely unwell, who has no background, and you're putting monitoring on them, you need to talk to them and break it down. And this sounds like it's implied and that it's barn door obvious, but it's really, really important to talk through the process of why you do this and why you're putting monitoring on them. But it's also an important part of basic consent, which is that I'm going to do an ECG on you. And for me, especially as a male nurse in an ED, Culturally, sometimes that is not the most appropriate thing to do. And so asking your patient, if you're a male with a female or vice versa, or if they just seem a little bit off, saying, I need to do an ECG, are you comfortable with me doing it as a male or whatever? And I think that goes a long way, because that then initiates a process with the patient. They go, yes, I'm okay. Please continue. Cool. I've had it maybe once or twice, and it's only ever happened in New Zealand, and it's normally been with Māori patients. They've said, oh, I'm sorry, I don't feel comfortable with you as a male, and that's fine. Hey, listen, female colleague can come in and do the job. Cool, thank you. So, moving on, we need to check the name, date of birth, time and date, the indication for why we do it, previous or any subsequent ECGs we need to reference to. And that's hard pre-hospitally, I know, but if you're in a hospital setting and have previous ECGs, then you need to use that as a baseline to reference if you see any acute changes or any pathological changes to your patient's heart. But if it's part of, say, a post-thrombolysis or antiplatelet therapy patient who's having a MI or whatever, so a myocardial infarction, a heart attack, you need to have it as part of a serialized system. And so numbering them is really important, stacking them, underlining the time for subsequent or serial ECGs is really important, okay, because that understands the sequence of movement of your ECGs. Now, I talk about this from a hospital-centric view, that we put a sticker on it for our patient, and those have a unique identifier, right? So they're URN or URM, so unique registered medical number or medical number or whatever you want to call it. In New Zealand, we call it an NHI. In the services, we could use their service details, so their service number, their full name, and their date of birth. Boom, you've got 3 unique identifiers. If you don't have stickers, enter them into the machine, and then when you finish with your patient, you discharge them off your Zol MD if you're in defense, or write them down manually after you print out the rhythm strip. And then that way you know beyond a doubt that that is your patient's rhythm strip or ECG. And the reason why I say this is because I've had this twice in my career so far, my short career, where we have nearly thrombolized the wrong patient. And I won't mention what hospitals it happened in, but these 2 separate occasions we nearly thrombolized people who did not present for a heart issue. And so this is the important part of why we do name, date of birth, time and date, serialized, indication, etc. And these may sound like over-the-top things to do to your ECGs, but it's really important. So the other things we need to check are the calibration, the rate, the rhythm, the access, and the elements of the tracing in each lead. Calibration is important. We make sure that our devices are calibrated every year, but also that they're calibrated to the rhythm strip that you put in, so the size of the paper. And that's more important in those big 12-lead ECG machines than it is more so in, say, a Tempest or a Zol or whatever. Rate is important. We'll talk about how we can check rate, so the R interval and the P interval if you wanted to use that. The rhythm, obviously that's very important, but access is more important in that ischemic heart disease patient, heart failure patients, because access deviation comes in with, say, left ventricle enlargement in prolonged pathology of, say, heart failure. So access deviation is really important. But then elements of the tracing in each lead, we specifically should be looking at that to make sure that we're minimizing artifact, so movement, or electrical interference from, say, 240 volt power or 230 volt power. And those are the basic things about making sure if the bed is interfering, we'll see the fluttering of the electricity coming off the wall. And I've seen that a couple of times in poorly earthed facilities. But also it's about telling the patient to stay still. So just take some normal breaths for me if you can. Try not to speak. Just give me 2 seconds. I'm just going to do this ECG. But then also, if it's a Parkinson's patient or someone has Parkinsonism or is hypothermic, then helping them stay still by gently isolating their limbs to stop that artifact from forming. So, the elements of the tracing. We've got some of our rhythms and our complexes and intervals from 2 slides previous. We've got the P wave. Now the P wave we need to look at, and that's important. The basics of looking at a rhythm strip, we need to find a P wave, okay? And that's the magnitude and the shape of the P wave is the best place to start. So is there a P wave present? Just ask yourself that every time you pick up a rhythm strip or an ECG. Can I see a P wave in any one of my leads? Because if it's not there, more than likely it's going to be atrial fibrillation. PR intervals. These are really important, but the normal PR interval, because this is all about identifying and seeing the normal, is 3 to 5 small squares, and that's 0.12 to 0.2 seconds. So that's what normal looks like. We need to identify pathological Q waves, and a pathological Q wave can be for a number of reasons. It can be for toxicity from medications, overdoses. It can be pathology of the heart and advanced physiology where things are beginning to change from failure, for example. Same with QRS complexes. We need to look at the magnitude, the duration, and the shape. And we've had previous slides about what a normal QRS complex is. Feel free to go back and have a look again at the QRS complex or have a look in the show notes. A normal QRS complex should be less than 3 small squares or 0.12 seconds in duration. The ST segment for a normal sinus rhythm, it should be isoelectric, so that's meaning that it's going in a particular direction, okay? And we know what normal looks like from the previous slides, and if you need to, have a look in the show notes. T wave, we need to have a look at the magnitude of it and direction, because again, T wave inversion can be a sign of old ischemia from a previous heart attack, but also pronounced T waves or ST segments as well can be part of, say, a myocardial infarction. Okay, our QT intervals start at the QRS and end at the T, and normally they're less than 2 big squares or at 0.4 seconds. So at 60 beats a minute, that's what's normal. And we know that a normal rate is 60 to 100 beats per minute. And a QTC or a QT complex is the QT over the RR interval. And that makes sense when you break it down and look at the QT versus the RR interval. Some machines will give you an interpretation of what they see per an algorithm that the machine puts out, and it will say abnormal ECG, suspected myocardial infarction. Now, I eliminate that algorithm every time I look at an ECG. I'm never going to let the machine bias my diagnosis and my interpretation of what I see, because I want to look at what right looks like and what is normal. And that's what this slide is about. Don't let your bias be formed clinically by what a machine interprets. Okay? Those are helpful, yes, as a secondary, but you take the full holistic picture, what the patient reports subjectively, what you see objectively, and then what you combine to make a diagnosis off that. So, when we look at a rhythm, we want to check if it's sinus, meaning it's normal and regular, or if it's not sinus. And so it breaks it down basically into the morphology of a sinus rhythm. This can be sinus bradycardia or sinus tachycardia or normal sinus rhythm, etc., etc. And that's basically everything is normal as it should be per the last slide, with intervals, with timings, with our RR interval, our QTC is normal, we have a P wave, etc., etc. Versus, is it not sinus? So is there no P wave, etc., etc. And that comes down to ventricular rhythms and supraventricular rhythms. So SVT, VT, VF. Cool. And those are our supraventricular tachycardia. SVT is obviously a detriment to our patients acutely, but VT and VF, especially unconscious, are a deadly rhythm that we need to address as per NZRC or our ANS core guidelines. So, slide in front of you, feel free to pull out your show notes. A good understanding of a normal ECG is the presence of a P wave. We talked about that before, and that would be absent in AF. We talk about this later on in the presentation. Following that is, if we were to use line 2 at the very bottom of the ECG, we want to go on the R interval. And it's hard to interpret this while I speak to you, but basically we would take a piece of paper and we would mark the R interval and then the next R interval using a biro pen. And we annotate the distance between the first R interval and the second R interval. And then we go along using that marker of blank paper and basically slide it from R interval to R interval all the way along lead 2 down the bottom to see whether or not it's normal and regular, okay? And that's a good indicator that we're getting a regular rhythm. Because say if we get atrial fibrillation, we're going to have an irregular rhythm and our RR intervals will be off. But obviously we're going to have an absence of the P wave. And then when we go through the remainder of it, we can see that there is no elevation in our, say, lateral leads from V2s through to V5 or V4. We can see that there is no inversion of the T wave. We can see that it's normal for the AVR to have inversion, and that we have positive affliction for our second lead and for our AVF, for example. So all those normal things that we should be looking for. And feel free to use your show notes or an ECG that you print off Google that's normal sinus rhythm to do all these things like the box technique or the paper technique to be able to check that you are getting a regular rhythm. So we've talked about what normal is and the elements of the tracing, but the normal ECG should have a sinus rhythm, which is P before QRS. We should have a rate of 50 to 100 beats a minute or 60 to 100 beats a minute, depending on what textbook you look at. The axis is 90 degrees to minus 30 degrees, and this is about axis deviation with heart failure, etc. The intervals are the PR interval from 0.12 seconds to 0.20 seconds, and the QRS should be less than 12 or 0.12. And so some machines will give you this on the top of the ECG strip or rhythm when it gets printed out, but you shouldn't rely solely on that. You should be able to count it using either the paper boxes that are on the machine and come out in the paper, or otherwise using the paper method as I talked about before. Cool, so this is from obviously a machine probably on a ward or an ED or an anesthetics or an ICU. And this has some of the basics on it. And you can see at the top left, the rate, the PR interval, the QT, the QTC. You can see the axis with the QRS and the T wave. You can then see that this is a female who is 59 kg and 165 centimeters. And they've annotated that they've got artifact in this. Now, just looking at the screen, I can see some artifact in lead 3 and lead 1, which is a little dirty, and that might be from movement prior to the ECG button being hit, but it's not enough to totally eliminate this ECG from being used with this patient. I mean, if we're going to be perfect, we'd reprint this, but this is a good example of a good ECG, and then the person who's done it has annotated that there is artifact, and they've written that up in pen up the top, nice and tidy, and they've said who they are. So they basically said, top right hand corner, I am AR, so assumedly their initials, and that might be the protocol for their department. So let's just go back to some basics, because this is all about low and slow. What you need to look for, are the limb leads set up correctly? Are they in the right place? Because as I said before, if you invert the limb leads, if you go left arm to right arm and right arm to left arm, for example, you will then get T-wave inversion. T-wave inversion is a sign of old damage or ischemia to the heart. And so you need to make sure that your limb leads are set up correctly before you press the ECG button. Are the ECG chest leads set up correctly? Is V1 in that fourth intercostal space? Have you gone V4, back to V3, 5 and 6? And is the ECG free of artifact? Is the patient moving around heaps? Are they shivering? Is there Parkinsonism from, say, Parkinson's disease, etc.? If there is, help them stay still, or just remind them, hey, can you just stay still for a second? Now, for some people, as I've acknowledged, that might be a difficult process to do, but we're smart enough to try and figure it out. So is the ECG set up correctly? Some further things. With limb leads, AVR should always be negative. With lead 1, it should always be positive. With the chest leads, R wave progression is small. And so a good way of remembering this in your chest leads is small to tall. Okay, small to tall. So there is an R wave progression. And that's really important. Those basics are what help break down what a normal ECG is. And if we go through left limb, left side, right limb, right side, V1, 2, 3, 4, 5, 6, cool, great. Okay, small to tall. Okay, AVR is negative, lead 1 is positive, great, cool. Okay, I've got a good ECG there. And so if we look at it on this one here, so from that previous slide, let's use our rules to establish whether or not this is a normal ECG. So AVR, is AVR negative? No, it is not. So see how it's going along the piece of paper and then going upwards. It's an upward stroke. That is a representation that it's probably not the correct limb leads. If we look at lead 1 up in the top left there, we can see that it is inflicted and going negatively. It's going down. And so our limb leads are probably inverted here. And that is being reinforced by V1, the T-wave inversion. So it's actually everted, so it's going upwards. So that's bad. And then if we look at the chest leads, are the chest leads going small to tall from V1 to V6? Well, yeah, they are. So the chest leads here aren't the problem, are they? It's the AVR and then the lead 1 up the top left-hand side, which are our problems. So our limb leads are in the wrong place, and it's been reinforced by V1. So good problem solving, well done. So other problems with ECGs: artifact, electrical interference, muscle tremor, and a wandering baseline. So artifact, movement of the patient. So is the machine moving? Are the cables jiggling around? There's a series of things that could interfere with artifact. Electrical interference, as I've said, this is quite common. I've had this previously with beds that have been poorly wired and earthed. I won't mention the hospital, but it is in New Zealand. Muscle tremor, Parkinson's patients, hypothermia patients, etc., etc. And then wandering baseline. Now, I'm sure some of you may be inquisitive, but the wandering baseline patient may be that freshly cardioverted, electrically or pharmacologically, and they may be coming post sedation or procedure and then have a wandering baseline. And so you have to wait for there to be cardiac stability post, say, administration of adenosine or post-shock to make sure that the wandering baseline is coming back to its normalcy. And so that's all about being patient and capturing the image or the rhythm as you need it. Cool. All right, find the artifact. Now, this one's been stuck out like dog's nuts, but you can see it in the 1 and 3 leads in the left-hand side. If we go through from the top left, we can see all the data is correct. We've got the age, the date, the time, who it is, how much they weigh, how tall they are. That's cool, great, cool. Operator, the initials are in there. And the machine has not interpreted this rhythm. And it's probably because there's artifact, to be honest. But there you go. That's an example of artifact and why we need to look out for it. Muscle tremor in this one, we can see it in lead 1, lead 3, and it's been annotated as artifact. If it's muscle tremor or artifact, it doesn't matter, just put artifact. That's fine. So an electrical interference in this one you can see in 1 and 2. Those are really good examples of 1 and 2. So basic observations. One of the first things we look for is the heart rate, and we can use that using the box or the paper method. We can also find that from the data that the machine puts in the top of the rhythm strip. We shouldn't depend always on a rhythm strip to give us data. We should do it ourselves until we have a good understanding of what the rate looks like from expertly handling ECGs. Then we shouldn't be trusting the machine to do it for us. And we'll talk about that in a second. Rhythm, regular or sinus, and that's about looking for that P wave. Is there a P wave there? Good, cool. Is it regular? So is the RR interval regular? Okay. Intervals, we want to look at the PR and the QRS, and again, there are techniques to doing that, and we'll talk about that in a second. And then, is the ST segment elevated or pronounced? Because if it's pronounced, especially in our V2 to 5 lead, then that could be an indicator of a myocardial infarction, obviously. If the heart rate is regular, count the number of large squares between the R waves. And those are the pronounced ones, not the small boxes that go between, but the pronounced bolded lines on your ECG paper. So the large squares between, a good way of doing this is doing rate equals 300 over RR. And so RR can be 4 large squares in this instance. So let's say we've counted 4 large squares on our ECG paper. We go 300 divided by 4, and that equals 75 beats per minute. Okay, and that's known as the box method, You can use the paper method I talked about previously, but the box method is one of the most accurate ones. So look at the number of large boxes before the R waves, and then use this method finding the heart rate. Just remember that 2.5 boxes or less is a critical value for tachycardia. So if you see 2.5 boxes or less, you know that this patient is in a very, very rapid rhythm. And 7 or more boxes is critical for normally bradycardia. So that's a really good indicator. You're like, oh shit, my R waves are split across 7 or more boxes. This patient has an incredibly slow heart rate. So this rhythm strip is a good place to start. And so we need to have a look at it and see, is it regular or irregular? And how many large boxes are between the R waves? Now feel free to use the show notes here, but from our R wave or intervals, we have 5 large boxes between each R wave. So feel free to use your paper, pause the video, have a look, but it's 5 large boxes between, which equals 60 beats per minute, 60 beats per minute. This one here, we've got some basic data in the top left-hand corner. If we look at the complexes, we want to have a look and see if they're regular or irregular. So are they on each box each time, and how regular is that interval between? And is there a P wave? So if we look at the R interval here, it doesn't look regular to me, and there is no P wave. And so I strongly suspect in this patient that this is hyperkalemia or a left ventricular hypertrophy in a heart failure patient, but more likely a hyperkalemia than that. So rhythm, sinus rhythm is a cardiac impulse that originates from the sinus node. Every QRS is preceded by a P wave. Cool, so that is a normal sinus rhythm. Moving on, so ectopic beats. One of the most common ectopic beats that you'll see is a multifocal preventricular complex, or PVC. Unlike normal contractions, PVCs appear wide and bizarre on the ECG. These PVCs may be unifocal or multifocal. Unifocal PVCs arise from the same irritable site in the ventricle, whereas multifocal PVCs result from irritation in multiple ventricular cells. Each contraction looks different on the ECG, and so if you're getting pop-ups and pop-downs, that might be a multifocal PVC, as you see on the screen in front of you. Whereas if you get a unifocal, which is common pretty much every time, that is probably from the same site in the heart. Multifocal PVCs can be an electrical issue that is baseline for that patient, and we get that every now and again in practice. Had it recently with a burns patient here in the Outback, a 19-year-old who's fit, healthy and well. His electrolytes were unremarkable, and he had superficial burns and it had never been picked up on any ECGs previous. But sometimes multifocal PVCs in particular represent an electricity problem that can arise as, say, supraventricular tachycardia, but also can be an electrolyte disturbance from medications, physiology, but also sometimes the mechanism or the injury that the patient sustains. And so multifocal PVCs in particular can be a representation of badness and a combat indicator that you need to scoot your patient, especially if they're symptomatic. So if they say, I have chest pain, and then they get a multifocal PVC, you are looking at a pre-arrest status potentially. Yep. So that means drive faster, or get this person to more definitive care, or pump off an ECG and monitor and observe the 12 lead further. So the PR interval. The PR interval is measured when we have the start of our P wave to the start of the QRS complex. And I'm pretty much reading off the slide there, but this next slide is a good demonstration of understanding the PR interval. And so we can see, if we look at our rhythm strip, feel free to pick up your show notes if you've got them, is you want to measure the start of your P wave to the start of the QRS. So have a look for your P wave, measure to the start of your QRS complex, and check if your interval is regular. V3 is a good place to have a look at this, V2, and the bottom strip being V5 has got a regular pronounced rhythm that you can go along from your P wave all the way through to your QRS. So this is a presentation of a 40-year-old man with chest pains and palpitations. This is a patient of mine, and they have a short PR interval between the P wave to the start of the R complex, and they have something called Wolff-Parkinson's White syndrome, or WPW. It is a relatively common heart condition that causes the heart to beat abnormally fast for periods of time. The start is an extra electrical connection to the heart. This problem with the heart is present at birth and it's congenital, although symptoms may not develop until later life, and so obviously this is a 40-year-old. The extra electrical pathway in Wolff-Parkinson's White syndrome appears between the heart's upper and lower chambers, so the atria and the ventricles, and is present at birth. Symptoms most often appear between the ages of 11 and 50 and may include a rapid pounding heartbeat, some dizziness, and lightheadedness, and normally corresponds with low blood pressure sometimes. Poor perfusion, they'll look very mottled, they'll probably appear quite cold and a bit grey sometimes. Treatment may involve the use of medication or being sent to a catheterization lab or a cath lab to get an ablation, so basically a burn to the part of the heart that's playing up. In rare instances, an electric shock may be used to restore the rhythm, so you get a cardioversion. More likely in a resus bay than pre-hospitally, unless it's life-threatening. All right, so heart blocks. There's a summary of them. First degree is a constant PR. It's greater than 0.2 seconds. Second degree type 1 is known as winky back, and the PR interval widens over subsequent beats. Then it drops a QRS and then it comes back again and it continues to do that. Type 2, second degree, is a constant PR interval and then a QRS is dropped. And so to delineate between the two, you need to look over subsequent beats versus a constant QRS being dropped. Third degree has no discernible relationship between the P waves and the QRS. So this is a first degree. Note the constant PRs in lead 2. And again, feel free to pause this, but you can see that the difference between the PR interval is greater than 0.2 of a second, basically, and that's really easy to see in number 2 lead down the bottom. This is second degree type 1, which is Winkerback. Note the PR interval widens, and then over subsequent beats it drops the QRS. So you can see lead 2 again down the bottom. Great representation. 1, 2, 3 beats. Has a beat and then pauses temporarily and does it again. So that's Winkerback. Okay, that's type 1. And then second degree type 2, the PR is constant and then a QRS is dropped. And you can see that it's a bit harder with this rhythm strip, but V6 down the bottom again is a good place to look, to measure up and have a look at the paper, do your box method or do your timing if you need to. And then you can see that the PR is constant and then you have a drop of the rhythm. So what you see on the screen here is a third degree AV block. It's characterized by a complete AV node dissociation, and it has no supraventricular impulse conducted to the ventricles. And a good rhythm strip to see is V6 down the bottom. So we need to look at the Q wave, and this is important with QRS complexes. And basically the criteria is, as you see on the screen, pathological Q waves will appear normal in 1, 2, 3 AVL, and 5 and 6, but if it's anywhere else, that pathological Q wave indifference is important. And you can see pathological Q waves in V3 and 4 in this picture. We need to have a look at the QRS height. After all, everything else we've been doing, the QRS height, if the complexes in the chest look very tall, then we need to consider left ventricular hypertrophy. So left ventricular hypertrophy is one of the first things that happens in cardiomyogaly, which is enlargement of the heart muscle. Cardiomyogaly can occur in that older heart failure patient who may have already had a myocardial infarction or a heart attack. May also appear in patients that have abused cocaine, methamphetamine, which is quite common over here in Aussie. Meth is obviously making a rise in New Zealand, so we need to be aware of that with young patients. It can also occur in people that have lived very stressed, hard lives, worked the land, used their body for that. That can cause hypertrophy, but also cardiomyogaly. And some endurance sports athletes who have obviously used their body to get across land. Obviously it's enlarged the heart. But then you can also just have congenital defects with left ventricular hypertrophy in those younger people. So if the depth of the S wave in V1 added to the height of the R wave in V6 comes to more than 35 millimeter, then left ventricular hypertrophy is present. That's a bit naff if you start getting out a ruler on the job and checking your added height. Yeah, that's a bit naff, but hey, there you go. The QRS width. Now this is really important. The width of the QRS complex should be less than 3 small squares or 0.12 seconds. Some texts say that less than 0.10 or 2.5 squares is appropriate criteria, but 3 small squares is fine. If the QRS is wider than this, it usually suggests a ventricular problem, and it's normally a right bundle branch block or a left bundle branch block. So, looking at it, we need to have a look at the width, and it's useful to look at V1 and V6 in this. So if you want to check your QRS width, look at V1 and V6. And left bundle branch block and right bundle branch block can be remembered by the following mnemonic. William Marrow. Okay, so if there's a W and an M, you've got a left bundle branch block. If you've got an M and a W, so it's then inverted, you've got a right bundle branch block. And you'll see what I mean in a second on this next slide. Right bundle branch block can be caused by either infarction, so being a heart attack, or fibrosis, which is part of the aging process in the heart, and that's pretty normal in older patients. So left bundle branch block we see here, V1 has our W, and V6 has our M, and you can see they're quite pronounced. So it makes a W shape with the inflection on the V1, and then you have the M coming up and making that shape directly in the middle of the rhythm. New onset of left bundle branch block can occur, and if the patient reports chest pain and you see this W and M in V1 and 6, then you need to think about a heart attack, so a myocardial infarction. It's very difficult to interpret the ST segments from a left bundle branch block. So if we do our William here, and we look at V1, we can see a W shape in V1, and then we can see an M shape. It's not very pronounced in V6, especially in that middle part of V6, but yeah, it is there. And so this is a left bundle branch block. So if this was to come out on your ECG, a really good thing to ask your patient, do you have any active chest pain at the moment, ma'am, sir? And if that's the case, then they need to be sent away. Right bundle branch block, this is called an RSR pattern as well. It's very common to call it an RSR in the States and Canada, less so over our side of the world. But if there is a right bundle branch block, there is an M and a W. So this is Morrow. So remember, William Morrow. So right bundle branch block is the Morrow. So you see an M in V1, a W in V6. In this particular example, it's probably not the best representation of the W, but you can definitely see the M. And this can just occur in healthy people. And they normally have a normal QRS and a right bundle branch block, which is partial. This is a good ECG to see the Morrow. So the M, even though you can't see the top of the complexes, you can see there's an arch in V1, and you can see the W forming in V6. So with our myocardial infarctions, within hours the T waves will be peaked, and the ST segment will begin to rise, okay? So within hours. Within 24 hours, the T wave then inverts, and it may or may not be present. That's probably a 50-50 in my experience. But the ST elevation begins to resolve automatically. If the left ventricle aneurysm forms on this, an ST elevation may also be present. So an aneurysm versus a STEMI or ST elevated myocardial infarction. You know, those are the two things you need to look at when you see ST elevation. But within a few days, you're going to get pathological Q waves, as we talked about a couple of slides back, and they normally persist. So if you've checked your limb leads and you've got left, right, and you've still got T wave inversion, and then you're getting pathological Q waves as well, that is cause for concern post a myocardial infarction. And so again, this comes down to the subjective and objective. The objective, what you see on the slide, the subjective, patient is reporting chest pain, is saying, I feel horrible, and then added objective signs, which are shortness of breath, an increased respiratory rate, tachycardia, poor blood pressure, all those basics that would indicate something's not quite right. So this is an anterior myocardial infarction appearing in the V2, 3, 4, and 5 strip. These are very, 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 very pronounced ST segments. So this is a STEMI, so a ST elevated myocardial infarction. And these are obviously going across the left ventricle. And this is obviously a big deal because for those of you who are unaware, if it's going across the left ventricle, which is part of the heart that works the hardest, that's obviously lethal and going to cause some major issues for perfusion and ongoing conductivity in the heart. This is turning up in the inferior leads, so this is an inferior MI. So this is good rationalization for doing a posterior ECG. And this would be very, very hard to pick unless you were trained or observed in seeing what you're going for. If your patient, for example, is giving you those subjective signs of, hey, I've got chest pain and I've been cold, sweaty, and they're looking a little chunky, haven't lived the best life up till now, and you're getting that, see this on your strip, then that's a good indicator of an inferior MI. So this is a really good example of a T-wave inverted MI, and this is that post 12 hour of onset of symptoms, say. And the classic example in Australasia is that larger BMI male patient, and they're middle-aged. They present with their wife bringing them, or their partner saying, you need to go to the hospital, and it's 12 hours after onset of symptoms. They were reported, 12 hours previously, short of breath, grey. They were really exerted, at rest. They were just absolutely trying to draw in that air, and the partner said that they looked absolutely horrible, but also they maybe have reported they felt like they were about to die, or it was impending doom. This T-wave inversion is a very good example of the muscle trying to recover from that heart attack. Atrial fibrillation. Some of the features with atrial fibrillation is that there might be tachycardia. The rhythm is usually irregular, and there's no P waves, so they're not discernible. Instead, there's like a shaky baseline. It's a shaky baseline. And so this is because there's no order in the atrial polarization, or depolarization rather, and different areas of the atrium are depolarizing at will. And this is a good rhythm strip to see that. You can see there's a P wave in the bottom one, the purple arrow, whereas in the top arrow, the red one, it's that baseline is shaky, and you can see it's irregular. So the R waves are definitely not regular. There's no rhythm to that. Got that white boy rhythm. And this is a good example. You can see in lead 2 to the left-hand side in the middle there that the RR interval is out of whack. It's out of whack. And the baseline is a little bit shaky, but the RR is a good combat indicator to badness. Atrial flutter. This is a sawtooth pattern, so it looks like it's at the lumber yard cutting up some wood, and you can see that in the bottom strip. You can definitely see a pronounced sawtooth pattern, and the atrial rate is around about 300 beats per minute. So if you palpate the patient's radial pulse or carotid, you're going to get this really rapid, flicking, fluttery pulse. You're going to get really poor blood pressure and output. They're going to look really horrible, diaphoretic, short of breath. And so this is a good example of an atrial flutter. Same again, you can see down in AVF, lead 2 and lead 3 in the bottom left, that sawtooth pattern, really pronounced. So these are really good examples. And just because I like it so much, there's some more there, lead 3, AVF, lead 2. So the RR interval is relatively regular, but that sawtooth pattern is very pronounced. And if the patient was symptomatic of this, again, shortness of breath, poor output, their hands are shut down and a bit cold, then this is a really good rhythm strip to back up those objective and subjective signs. Ventricular tachycardia. Hey, so VT, one of our shock or not rhythms, and our ANSCORE advanced rhythms to know. Ventricular tachycardia is obviously one of our big ones to know, along with VF obviously, and fine VF and VF have a very pronounced representation on a rhythm strip, so I'd feel less inclined to talk about them. However, VT we can see can be quite easily mistaken with a short sawtooth pattern of an atrial flutter, and so the delineation here is that there is no complex being formed in, say, the V leads. So you can't see a QRS forming at all. and so the patient obviously would either be unconscious or have no outputs. And so what's a good thing to check? Is the patient breathing? Basic life support. Is the patient breathing to start? Do they have a radial pulse? Now I say that with hesitancy because our prime reference should be a carotid pulse. And any patient, cardiac, trauma, anything like that, the first pulse we should check if we don't see breathing is the carotid, okay? So conscious or unconscious VT, check their output. Are they breathing? No. Have they got a carotid pulse? No. Start CPR. Yes. Okay. Observe. Let's give them support. Let's put pads on them. Let's get IV access, all that good stuff. Okay, just some basics to reinforce what we've learnt. Thank you so much for hanging through so far. I'll just finish on this. Just remember, correct electrode placement is really important. Left to left, the patient's left, not yours. The V leads, fourth intercostal space, then working down, V4, then come back to V3. Make sure the left leg is to left. The right or the dummy lead is to the right. Good way of checking a regular rate is the R interval, and always look for a P wave. Make sure it's a sinus rhythm. We've talked about rate, we've talked about the box method and the paper method, and just remember your basic values of, say, the QT complex. Cool, thank you very much for listening. See you later.